Linda, show us some important bony landmarks on the anterior chest.
Sure. So we're going to begin with the jugular notch. I want you to feel for the soft area, and this is a really important marker. So this is the beginning of this bone, which is called the manubrium. And I want you to bring your finger down the manubrium until you feel a rise. When you feel a rise, that's a really important landmark. It's so important that we've named 3 different names for it. It's called the manubrial sternal junction, it's called the sternal angle, and it's also called the angle of Lewis that we actually refer to as Louis.
So why is it important?
That's really important because that's your marker for the second rib. So find the jugular notch, come down. At the angle of Louis, you're going to feel a bone. That is your second rib. Below it is your second intercostal space, third rib, third intercostal space, etc. This is the body of the sternum that ends in the xiphoid process.
Can you always feel the xiphoid process?
Not always. If somebody has extreme musculature, it's difficult to feel, but you can always feel this costal margin. Remember, costal means rib, so this is your costal margin. And it's important to note when you look at the costal margin, the angle right here. That angle should always be less than 90 degrees. There's also some other landmarks that we want to talk about when we look at the chest. One of them would be this line. Remember, this bone is the clavicle. We're going to take that clavicle and we're going to divide it in half. And that will be the mid-clavicular line. Similarly, if I took the sternum and I divided that in half, I would call it the mid-sternal line. And these will be really important features later on when we listen to heart and lung sounds.
Are there any important vertical lines in the axilla?
Yes, so we also need to be able to define where things are in space, and we're going to use these lines and we're going to term them, anterior axillary line, mid-axillary line, and posterior axillary line.
Can you feel the anterior axillary line?
Well, you can feel from the musculature coming down. And then I'm going to turn the patient, and posteriorly, we need to use bony landmarks to help us figure out where we are in space. And so this bone, obviously we know this bone is called the scapula. And we want to know some borders about it. So we have the superior border and we have the inferior border. Why do I care about the inferior border? Is that when I feel the inferior border, I know that the inferior border is approximating the 7th rib. So I know where I am in space. Similarly, I'm going to have to know where lungs are divided. So I'm going to have to use this area. So we know that this is the vertebral line. And if I drew a line down the middle, that would be the mid-vertebral line. I'm going to take my patient and I'm going to bend the patient's head forward. Can you see that there's a bump there? That bump corresponds typically with C7. So the 7th cervical vertebrae.
And what is it called? The 7th cervical vertebrae? Is that the vertebral prominence?
Yes, sorry, Bill. So the vertebral prominence, there are 7 cervical, there are 12 thoracic. So we are going to start counting from C7. We're going to count down T1, we're going to count down T2, and we're going to count down to T3. At T3, this is a really important landmark because this is where the lungs are going to be divided. Can you see the line I'm making? So it's an oblique line. So the lungs are going to be divided into upper lobes and lower lobes by this oblique right and left fissure that separates upper lobe from lower lobe.
We've now drawn the lungs and the lines of pleural reflection. And Linda, can you show us how these markings are used to do a chest exam?
Sure. We begin by understanding there's 5 lobes to the lung. There are 3 on the right and there are 2 on the left. And the lungs rise 1 inch above the inner 1/3 of the clavicle. So again, the lungs rise anteriorly 1 inch above the inner 1/3 of the clavicle, And then you can see that we have a marking drawn here. This is divide upper lobe from middle lobe. So we use the angle of Louis marking again, which is your second rib underneath the second intercostal space, third rib, etc., until I get to the fourth rib. At the fourth rib, I draw an imaginary line over to the fifth rib in the mid-axillary line. Because the ribs curve, what start at the fourth is the same as the fifth, therefore we call it a horizontal fissure separating upper lobe from middle lobe. Posteriorly, the lung was divided from T3, which I'll show you right now. At T3, we take the patient, we bend the patient's head forward. Can you see that there's a prominence there? It's typically C7. Underneath it, feel for the first prominence, T1, feel the second, T2. At T3, we draw an right and left oblique fissure that divides the lung posteriorly into upper lobe and lower lobe.
Linda, why can't we see the middle lobe in this view?
Because there is no middle lobe posteriorly. Posteriorly, you are only going to get upper lobe and lower lobe.
So you can only listen to it anteriorly.
Correct. You will never be able to hear a right middle lobe pneumonia posteriorly. You are only getting upper lobe and lower lobe posteriorly. So again at T3, the right and left oblique fissures divide the lung into upper lobe and lower lobe, and the line ends again at the sixth rib in the midclavicular line. So that's why we drew these lines before. So now we have right upper lobe, we have right middle lobe, and you can see anteriorly we only have this much space for the lower lobe.
So what are these dotted lines?
The dotted lines are the pleural reflection. That is, the lungs end anteriorly at the sixth rib, at the eighth rib in the mid-axillary line, and the 10th rib posteriorly. But if you think about what happens when you take a breath, you take a deep breath in, if you can, and what happens is his diaphragm pulls down, and his lungs will go into this recess. So now, where his right lung ended at the sixth rib, you can see that we're now going to extend to the eighth rib. So the eighth rib now anteriorly, the 10th rib in the mid-axillary line, and the 12th rib posteriorly. His lungs will descend down to this pleural reflection on maximum deep inspiration. So the lungs are constantly in an active process of moving up or moving down.
We've now drawn the borders of the heart in red and the position of the valves and the auscultation points for the valves. Linda, explain how you use this information to do a cardiac examination.
Sure. So we'll begin by understanding that the heart lays in the chest anteriorly underneath the sternum over into the left midclavicular line. The top of the heart is called the base of the heart. You can see we have a right sternal border. This right sternal border is primarily the right atrium. Over here, at the fifth intercostal space, left midclavicular line, that's what we call the apex of the heart, and the apex of the heart is the left ventricle. Here we have 4 valves drawn across the sternum obliquely, starting about the 3rd rib and going to the 4th intercostal space. And how they are is the first one is pulmonic, then we have aortic, then we have mitral, and then we have tricuspid. Those are where the valves are, but that's not where the valves are heard best. So now you need to understand, where will we listen? Where we'll listen is for each valve in a particular area. We are going to go back to the angle of Louis again. Knowing the angle of Louis is the marker for the second rib, the second intercostal space on the right sternal border, where you can see the heart is not, is where I hear the aortic valve best. So I will put my stethoscope right in that position and listen for S1 and S2, which you know as lubbed up. So I will listen here for the aortic area. Now I will move my finger laterally, staying again at the second intercostal space, but at the left sternal border, that will be pulmonic area. And again, I listen for S1, S2, or lub-dub. I now move down one intercostal space. You see I'm staying on the left sternal border now. This is what we call Erb's point. Erb's point is the third intercostal space, left sternal border. This is where S1 and S2 are heard equally as loud. I go down one more intercostal space, so now I am in the fourth intercostal space, left sternal border. This is the tricuspid valve. Again, listening for S1 and S2. Now I need to move over to the fifth intercostal space, left midclavicular line. I'm using that line again, and I am going to listen in this area, and this area is the mitral area. This area also is known as the PMI, or the point of maximum impulse. It is where the left ventricle hits against the chest wall. You can observe for it, and then you can use your hands to palpate for this area.
We now draw some of the important structures in the superior mediastinum. That is the region of the thorax immediately superior to the heart. And as we look here, we can see the arch of the aorta arching off to the right and coursing around behind the manubrium of the sternum, doing so close to the sternal angle, passing posterior to manubrium. And then we also draw the pulmonary trunk headed to the left and then dividing into the right and left pulmonary trunks, and then further dividing into the lobar arteries, 3 on the right and 2 on the left, as we've discussed. In the midline here, we draw the tracheal rings, and then for reasons of clarity here, we've continued the trachea as a single line in the midline here. We can see it dividing into a right and left mainstem bronchus, and we note here that the right mainstem bronchus is shorter, straighter, and more vertical than the one on the left.